Causes of hemoptysis. When a patient presents with hemoptysis, the three things very important. Number one, if the patient have cancer, if the patient have tuberculosis or pulmonary infarction. These three things is life-threatening and dangerous. So investigation and history should focus on this. Number one, bronchial disease, bronchogenic carcinoma, bronchiectasis, acute bronchitis, bronchial adenoma. These are the bronchial diseases. Parenchymal disease, these are tuberculosis, lung abscess, pneumococcal pneumonia, actinomycosis, etc. Lung vascular disease, these are pulmonary infarction, polyarteritis nodosa, and Gould-Pastus syndrome. Number 3, cardiovascular, it is mitral stenosis and acute LVF, and blood disorder, leukemia and hemophilia. So now, lung cancer risk factor. These are blood streaked sputum for more than 2 weeks, smoker for more than 40 years, and more than 40 pack year cigarette smoking, weight loss, clubbing, Horner syndrome, cervical lymphadenopathy. In X-ray, there is mass, cavitating lesion, unilateral hilar adenopathy, pleural effusion, particularly hemorrhagic. In favor of tuberculosis, suggestive clinical features are night sweat, fever, weight loss. Chest X-ray shows cavitary lesion or inhomogeneous opacity or patchy opacity, especially in the upper zone. Persistent consolidation that does not resolve after antibiotic for pneumonia, miliary TB, and pleural effusion. Aspiration of pleural effusion must be done. If this finding is found or there is suspicion of tuberculosis, then 3 or more sputum sample sent for acid-fast bacilli, AFB staining, and gene expert, and mycobacterial culture of the sputum, and empty if required. The clinical features suggestive of pulmonary infarction are rapid onset of pleuritic chest pain or dyspnea, symptom and sign of DVT such as unilateral leg swelling with pain, especially in the region of deep veins, and risk factor of deep vein thrombosis such as recent surgery and recent plaster, active malignancy, or patient taking cancer chemotherapy, etc. Specific risk factor, active malignancy, recent surgery, this I have already said, and new onset of frank hemoptysis with no other obvious cause. If these findings are fulfilled, then suspicion of pulmonary embolism you can do. Bronchiectasis, it is associated with clubbing, cyanosis, pulmonary hypertension, long-term purulent sputum formation, and sometimes with aggravation, and sometimes with hemoptysis. Bronchiectasis may also be post-tuberculosis, pneumonia, lung abscess associated with high fever and can easily be diagnosed. If a patient have a history of rheumatic fever, exertional dyspnea, orthopnea, paroxysmal nocturnal dyspnea, palpitation, sign of mitral stenosis or sign of pulmonary hypertension, then you must do an echocardiogram to exclude the cardiac disease. And history of prior history of myocardial infarction, or in the background of chronic stable angina, if the patient develop dyspnea, exertional dyspnea and paroxysmal nocturnal dyspnea, then you must do an echo for ICM, ischemic cardiomyopathy, and for regional wall motion abnormality as found in myocardial infarction. These are the causes of hemoptysis in a patient with post-TB. These are reactivation of tuberculosis, reinfection with tuberculosis, post-tuberculosis bronchiectasis, aspergilloma, that is fungal ball, and scar carcinoma. If a patient presents with rash, hematuria, digital infarction, point to an underlying systemic disease such as vasculitis. So management is according to cause, but I will discuss here the management of acute massive hemoptysis. Massive hemoptysis means more than 500 ml hemoptysis per day. So the patient should be kept upright, especially that portion of the lung should be upright where the disease is involved, and if you only know that, and patient is given with high flow oxygen, and then bronchoscopy in acute phase is difficult because it only finds blood in the bronchus, so it is avoided. Infusion of antifibrinolytic agent such as tranexamic acid or vasopressors such as terlipressin may limit the bleeding if radiology shows obvious central cause. Central cause means if a central bronchogenic carcinoma or adenoma is there, it causes collapse. So if you find collapse in chest x-ray, then a rigid bronchoscopy under general anesthesia and is done to stop bleeding. However, source of bleeding often is not visualized. Intubation and ventilation of the unaffected lung is done for patient's survival, and bronchial angiography done for embolism, and even emergency surgery is life-saving. So what are the investigation you will do? Investigation number 1, a chest x-ray you will do. Chest x-ray will show the evidence of pneumonia, tuberculosis, bronchogenic carcinoma, unilateral hilar lymphadenopathy, etc., or fungal ball in case of aspergilloma. Full blood count you will do, including clotting screen, because hemophilia and thrombocytopenia may cause bleeding. Including clotting screen means CT, and a bronchoscopy after acute bleeding has been settled when a central tumor is thought, and x-ray or not any pathology not visualized on chest x-ray, or chest x-ray shows collapse, then you will do a bronchoscopy that will do biopsy and histopathology, and then a sputum culture, sputum AFB stain, and sputum cytology for malignant cell is done. A CT pulmonary angiogram is done for thromboembolic disease and arteriovenous malformation or small tumor. I want to discuss about the investigation in case of hemoptysis. Again, these are number one, imaging, a chest radiograph. Number 2, fiber optic bronchoscopy. Number 3, contrast enhancing CT scan or HRCT. So chest x-ray, what will be found in chest x-ray? Malignancy, focal infection, mitral valvular disease, etc., or tuberculosis or bronchiectasis in advanced case you will find on chest x-ray. If chest x-ray finding are nothing, then a fiber optic bronchoscopy, especially if A is more than if carcinoma risk factor are present, and HRCT in suspected case of bronchiectasis, and CT chest also finds a localized bronchogenic carcinoma, and CT guided FNSC and histopathology FNSC is done for finding a bronchogenic carcinoma. So other factor, sputum, I have already discussed it. Blood test, blood count, that means a raised white cell and CRP suggest infection. ESR raised in infection, malignancy and vasculitis. Clotting screen for coagulopathies. LFT may be dearranged in metastatic lung cancer or liver failure. Urea and creatinine electrolyte for assessment of renal function if associated with vasculitis that involves the kidney. Corrected calcium will be high in bronchogenic carcinoma. D-dimer in case of thromboembolism, and autoantibody C-ANCA, C equal to W, that means C-ANCA in Wegener's granulomatosis. PMC, that means P-ANCA positive in M and C, microscopic polyangiitis. and Church-Strauss syndrome. Anti-glomerular basement membrane antibody if you think it is a case of Gould-Pasteur syndrome. And urine analysis you must do if the presence of red cell will indicate glomerulonephritis of pulmonary renal syndrome. Thank you.